Support comes from Hampton Roads Community Foundation, partnering with donors from all walks of life to improve southeastern Virginia through grants, scholarships, and leadership initiatives. Learn more at hamptonroadscf.org.
Hello, everyone. I'm Barbara Ham-Lee. You can find all kinds of amusing memes on social media about our show topic today, menopause. Like, real women don't have hot flashes, they have power surges. Or menopause, a pause while you reconsider men. Every woman's journey through this life stage is different, but there are ways to cope with the physical, mental, and emotional changes women experience in midlife. Up next on Another View on Health, a candid conversation about menopause for women and men. Stay tuned. Another View will be right back after this national, regional, and local news from NPR and WHRO News.
Discussing today's topics from an African-American perspective, this is Another View.
Good afternoon, everyone, and welcome to Another View. I'm Barbara Ham-Lee. Want to give a shout out to the folks from Gethsemane Community Baptist Church. Last night, I had the honor of moderating a discussion on the Black family, and we had Dr. Darlene Colson, and we had Mr. Alfonso Albert, and then we had Dr. Kurt Houston, and we talked about all aspects of the Black family. It was really moving, and I just wanted to say to them, thank you for inviting me. Thank you for trusting me to lead such an important conversation. And also want to recognize that we have some students from Chesapeake Public Schools shadowing us here at Another View and at WHRO Public Media today. From Western Branch High School, we have Joy, Kennedy, and Trey. From Indian River High School, Finn. And from Grassfield High School, Natalie joins us. So we hope you guys enjoy the show, and thank you so much for checking out Another View. There are several points in life when your parents give you the talk, the birds and the bees talk, and especially for African Americans, the talk about how to behave when you're stopped by police. There's the talk about education, careers, family. But what about the talk about menopause? It's a natural part of the cycle of life for women, but until recently, it was rarely discussed, privately or publicly. Now that's changing, and today we're going to talk about it with Dr. Betyshia Belardo. She's a triple board certified family medicine, obesity medicine, and menopause physician dedicated to optimizing the health and well-being of women. How are you, Dr. Belardo?
Doing well. How are you doing?
Good. I'm doing great. Thanks so much for joining us today.
Thank you for having me.
And my co-host, as always, for Another View on Health, the inimitable.
Oh, man.
The great.
Oh, thank you.
The magnificent.
Oh, that's what I'm talking about. Checks in the mail.
Dr. Keith Newby, who is a cardiologist and everything and a bunch of other things.
Yeah, other stuff too. You don't have to go through that. I appreciate it. Thank you. And good seeing you as always.
Thank you very much, sir. Definitely. I was at an event on Saturday night. I emceed the Chesapeake Bay Academy event, and people came up to me and they said, "We just love Dr. Newby." So,
Well, thank you. Thank you all out there very much. I appreciate it. Yeah, I try. I'm a work in progress, as they say.
So when I've told people that we were going to talk about menopause, the women were like, "Oh, I can't wait. I got so many questions. I have things to ask." So I want to start with the basics first, so that we all understand the terminology and so forth, because I didn't realize that there are actually 3 phases of this, right? Yeah. So you have perimenopause, you have menopause, and then you have postmenopause. So let's start with you, Dr. Belardo. Tell us what the differences are between that, kind of run the cycle for us.
Yeah. So starting with perimenopause, which you hit first, of course, can start anywhere around age 45. That's the average, but some women can actually start a little bit earlier, 35, 38. And that's just when your hormone levels just start to kind of become erratic between the estrogen and progesterone levels, and even the testosterone levels start to decline. But they're all over the place. They're up and down. So that's why you can have more of the symptoms. And menopause usually starts around age 50, 51 for average for women. And at that point, it's really just one day. So after you haven't had cycles for 12 consecutive months, that 12th day, that last month, you're in menopause, and then you're menopause forever. So then the next day is postmenopause until you keep living.
And can you still experience symptoms when you're in postmenopause?
You can, especially in the beginning phase of postmenopause, but towards, over time, symptoms do get better. And they do kind of wane off, but you can still experience symptoms for quite a bit of time.
And I was reading a study because in the realm of if America gets a cold, African Americans get pneumonia. Right. Black women tend to, they have found let me get it right. They reach menopause on average 8.5 months to a year earlier than white women, and the transition can last longer, often spanning 10 years.
Yes, and their symptoms can be even more severe. And that is true from the research, what they've shown.
Do we know why?
It's really kind of complicated. They have thought about some things that are related to kind of what they call weathering, which has to do with exposure to historical racism and the stress of that, and historical economic stress. So I know they're doing more studies on that, but that concept has been explored, especially with the SWAN study, when they were looking back at the African American women who were in the study and looking at their cultural and social economic status and comparing their symptoms. So I know there's more studies going on with that. And they also been looking at the actual genes of the women who were in the study in terms of seeing that there were more genetic, I guess we could say, like deleterious effects to their genes, where they would be more susceptible to certain conditions, more susceptible to even earlier death.
Yeah, I'd be curious about lifestyle with that as well.
Me too, yeah.
Because you think about the differences between really African Americans and whites, it goes beyond just the, skin tone or whatever. But I kind of wonder, you talk about stress levels, but just lifestyle itself, with things like obesity rates, exercise or lack of exercise rates, what we eat on a day-to-day basis, would that have impact? I don't really know, but that would be interesting study to look at.
Yeah, it would. I mean, in terms of like symptom management, those things do have a large impact. So it would be nice to actually to look back at that and see how much of that was studied at that time. But I know going forward, that's more of a focus going forward for sure.
So let's talk about some of the symptoms. I mean, we all know hot flashes, right?
Yeah.
But run down a couple of those, and do they happen to every woman, who goes through this?
Yeah, they don't happen to everybody, but of course the most common ones are hot flashes. Brain fog is very common. I hear about that a lot. Weight gain.
What does brain fog mean?
So it's when women feel like they have trouble with word finding, or just feel like they, can't. They go into a room and can't remember why they came in there for a minute.
Oh, that's what that's called.
Yes, yes.
Now I know what
exactly. Now we know there's a word for it.
Yes.
Before she's like, I just forgot. But it's real, and especially it can be really debilitating if it really affects a person's work. I've had some people tell me that they're used to giving presentations at work, and then they start noticing that they have trouble, kind of keeping up with how they normally would do it, or forgetting what to say next when they normally could just rattle through it. And then that causes more anxiety because they start becoming self-conscious about their, performance at work. At home, it can just be problematic when, you're just trying to get things done, and it takes longer because it takes longer to process information when that brain fog is happening. So that's definitely very common. Some less common things, like itchy ears, of course, dry skin, hair loss. I guess that's pretty common, actually. A lot of them complain about that. Dizziness, sometimes new onset or worsening anxiety. Some people who didn't have very much anxiety before will now all of a sudden notice it's severe or new. A lot of women start to find that they have ADHD type symptoms too. Sometimes they find that they were not diagnosed previously because it just gets worse in menopause or perimenopause, but before they were able to cope with it and they just never sought treatment to be, sought diagnosis for it. Yeah.
That's why the thermostats go up and down every night too.
Well, yeah, it just definitely changes in temperature, the night sweats.
Oh yeah.
Decreased libido, skin sensitivity, extreme fatigue, a lot of palpitations, trouble sleeping, trouble falling asleep, waking up in the middle of the night, not being able to go back to sleep, but just described more in a severe spectrum than usual.
Irritability,
yes. Just being easily irritated by anything, even sounds. I've had somebody just tell me that, sounds that didn't bother them can just sound louder. Kids walking through now sounds like they're stomping through and they're not. So things that can be really simple now sound just to be really irritating. So
I hope men are listening to this because they'll be the ones that'll be going,
yes,
you know what?
Yeah, I was going to say,
I understand, right?
Husbands out there, piece of advice, be patient.
Yes.
I know it's tough because sometimes, you get beat up on and we all have holes in our head to prove that we've been beat up a little bit, but be patient with the wives. Because it really is legitimate what they're going through. A lot of us will feel like they're just being some kind of way, but it's legitimate stuff.
Yeah, and every woman is going to go through it.
Yeah, they'll go through some phase of it. Yeah,
some
they may
more
not.
than others.
Yeah.
757-440-2665 or 1-800-940-2240 are the numbers to call to join our conversation. What questions do you have about perimenopause, menopause, or postmenopause? All of the pauses.
All the pauses, yes, all the pauses.
Let's talk about it. And also, I'd love to hear from you all about your personal experience and how you dealt with some of the symptoms, the more common symptoms that have happened. Some people do it with medication. Some people do it with other non-traditional medicines or health ways and so forth. So let's talk about that. 757-440-2665 or 1-800-940-2240. Adrian joins us from Raleigh, North Carolina. Hi, Adrian. You're on the air.
Hi. How's everyone? Thank you so much for having me.
Thank you for calling. What's your question?
Yes. At this point, the estradiol patch for menopause is almost impossible to obtain. And my question is, why are so few insurance-backed gynecologists writing prescriptions that can be obtained through compound pharmacies? You basically have to pay out of pocket for your prescriptions, and I'm trying to understand what the disconnect is.
Okay.
Oh, yes. So that can be fairly nuanced because it depends on if their office or practice works with a compounding pharmacy, depending on if they're either an independent practice or insurance-based practice. A lot of larger practices don't necessarily really work directly with compounding pharmacies. They just strictly go through the general insurance pharmacy network. Compounding pharmacies are independent. So usually when doctors are working with a compounding pharmacy, they have a direct contract with that pharmacy. And now as far as independent OBGYNs, again, it just depends on if they're doing that really, because it's not part of the regular system. It depends on also how comfortable they are with the compounding pharmacy itself, because they're all different, and you have to research how strong their program is, if they're really producing legitimate prescriptions that are of good quality. So really it's really independent.
Are they regulated, the compounding pharmacies?
Not to the same degree.
The same degree.
Yeah.
Okay.
I mean, they all, I think I've spoken to a few, but they all want to and really try to be, highly regulated and give the best product. But amongst physicians, the advice is to, if you're going to work with one, to vet them and, do your due diligence and your research. So if their office is not working directly with the compounding pharmacy, they can't really prescribe because they have to have a pharmacy to go through for
Gotcha.
that. Yeah.
I tell you the other thing, though, would be probably problematic is most of us as physicians, Dr. Belardo has a special expertise in this area, but most of us do not. When we go through training, very few of us actually get trained on how to manage menopause. You got to understand how to recognize it, how to diagnose it, and it's not like I don't think a lot of tests you can run to make that diagnosis. So then you have to understand how to treat it. And unlike in my world in cardiology, they spend so much time. We have so much research that we depend on that helps us make decisions. This is not like that. It's more of a nuance kind of. You just got to know how to manage it. So a lot of us just don't have the training that people
make
like
the
Dr.
prescription.
Belardo has to recognize it quickly and know what to do.
Thanks, Adrian, for the call. We really appreciate it. Speaking of that, one of the methods that a lot of women want to explore, and really I think it was because of a previous study, are afraid of, and that's the hormone therapy. Talk to us about that and how it can help or harm.
Yes, hormone therapy is very effective and safe, especially if depending on your personal risk factor profile. For most women, it is very safe, and for hot flashes, it is the most effective. But of course, it's not for everyone. I've seen a very good response with hormone therapy, and from what I've studied from it, it is safe, again, as long as you're within certain categories. So, and depending on the timing as well. So if you start treatment within the perimenopause period or before 60 or within 10 years of you going into menopause, that is the window of not only safety, but where you reap the benefits of preventative medicine in terms of like reduced risk for osteoporosis, Alzheimer's disease, reduced risk of heart disease, breast cancer. Those benefits you reap within that particular period. But for some women, if they've had a history of blood clots, of strokes, of heart disease, they may not be they have more red flags, I should say. But there are some nuances. You really do have to work with your primary care provider or OBGYN or menopause specialist to look at your history and to see what your risk factors are. And there are also some therapies that, regardless of those, are still safe, especially when it comes to vaginal estrogen, because that just localized to the vaginal area. It's not systemic, and it's pretty safe for almost anyone. But again, I always caution, depending on your history, you need to have everything looked at. But it is definitely safe. You just have to make sure you're not in a category where you have those risk factors where you have to either be cautious or you don't qualify. Also, too, sometimes migraines with aura may be an issue where that may not be the best option for you in terms of hormone therapy. Depending on whether or not someone's had breast cancer, doesn't mean that you're totally out of the option for it, but you really have to consider the type of cancer, other factors of health to see if that's a possibility for you. So it is safe. It's just that you have to make sure that you don't have any contraindications.
But to Dr. Newby's point, if you didn't learn about it, should women be looking for a a menopause specialist, or can they depend on their family practitioner or their OBGYN to be able to make those determinations as to whether hormone therapy is safe or not for them?
Yeah, I guess I'm a little biased. I do think they should be looking for a menopause specialist because with the menopause specialty, most of us have gone after the additional training because we recognize that we didn't have this depth of training in residency and medical school, especially me. But when I came in, it was after the WHI study. So we were kind of taught from more of a fierce perspective of just prescribe the lowest dose, shortest period of time, only if they really want it. Make sure you really explain all the risks, like really have these deep conversations. And now when they've gone back and looked at the study and they saw that women within these healthier windows had benefits, that's the newer information. So, and they found too, even in some OBGYN residencies, they may not have gone through certain depths. So it depends on if that particular OBGYN had that training or has sought that training, or that's their specialty. So I would say to look for menopause specialists, whether they're an OBGYN, family medicine, internal medicine, or any other disciplines. If they say that they have additional training in menopause, then they're going to know how to prescribe it.
Is there some sort of specific certification? Like if I walk in your office, is there something on the wall that says, I'm a menopause specialist?
Yes. It's through the Menopause Society.
Okay.
Yeah, it used to be known as NAMS, but they changed their name to the Menopause Society.
Actually,
yes.
The other thing, though, would be is access to those individuals, because how many people actually get trained as menopause specialists?
That's a very good question.
That would be maybe the only limiting factor, because if it's not that many out there, you may run into a problem of getting access to them. I always tell people, talk to your doctor, find out, because if they have like zero interest in menopause, that ain't the person you want to go to for that. I mean, there are some, because I'm listen, my name Bennett, I'm not in it. I stick to heart, but yeah, I have to learn some aspects of that because of the cross reactivity of how menopause can affect the heart. So I have to at least know to recognize it, but I don't try to manage that. But I do try to tell them if they have like excessive risk, they have to be careful with hormone therapy. I got a nice young, relatively young, healthy, exercise on a regular basis, no blood pressure problem, no diabetes, no cholesterol issue, they don't smoke, no family history. That's a lot safer profile for somebody to address with that versus the opposite. So a lot of it, you have to, that's why I kind of say you got to get into the lifestyle with a lot of patients and make sure they are at their best. That puts them in a safer profile to get these things done and to have that management.
And that's a good point, too, because you can have a practitioner who may not necessarily be certified, but they have an interest in menopause care. And so it's good to ask your doctor to see, do you feel comfortable prescribing it, talking about it? And if they do, they still can serve you, even if they're not certified, as long as they have an interest and they are studying the options and they know the red flags and how to prescribe. So it's just,
So since there's really no test that you can take to say that says you're in perimenopause because your hormones are all over the place, and so you can't take a blood test or something to measure that. What do you look for when someone comes in and they say something's up, doctor, and they're in their early 40s, I guess, to mid 40s, and they start to see these things? What are some of the questions that you ask them and that they should be asking you to figure out what's going on?
Yeah, so I really start with the history to find out their symptoms, because in perimenopause, the symptoms pretty much lead the diagnosis. So asking about if they're actually having hot flashes or night sweats, ask about how their sleep is, ask if they're having any changes in libido, how their relationships are. I also like to delve into nutrition as well to see where they're going, if they're focusing on more of a anti-inflammatory type diet, or if they're not really focusing on their diet at all. Like to also look into lifestyle of activity, and then like to go into other particular symptoms to make sure we're not missing other medical conditions, to see if they've ever had any history of any problems with anemia or their thyroid, see if they've had any surgeries. Of course, you're going to go over any history to see if they've had a hysterectomy, or if they've had any forms of cancer or treatment for that, because that can impact the ovarian function as well. And then once we kind of get a good idea of their history, kind of find out if they've tried anything as well. Have they tried any over-the-counter supplements? Have they tried any lifestyle changes? And then as far as perimenopause, I always give my patients the option to check their hormones, because there's not one particular test. The only problem is that because the hormone levels are up and down during perimenopause, the lab test is only looking at that one moment snapshot in time. But I always let them know it's okay to get a baseline. This is not going to dictate whether or not you want or can get treatment. But some women just want to see. I think knowledge is important. So just to kind of have an idea. And then later on, if you do go on to hormone therapy or in menopause and you have your labs checked again, you can compare and see and kind of just have that information. So it's not that you can't check lab work during perimenopause. It's just that I encourage women to not be discouraged if it doesn't show what we're looking for, because your symptoms is what we really care about. So we're not dismissing your symptoms because the labs look good.
Tell us some of the things that women say to you when they come in. What are some of the challenges that they're facing as they go through this?
Yeah, so the most common is trouble sleeping at night, whether it's trouble falling asleep because they're just tired but wired, so they're up late, they want to go to bed but they can't really fall asleep. They may have anxiety thinking about all things they got to do, or they go to sleep and they're waking up at 2 or 3 in the morning, can't get back to sleep.
I'm in a group chat with a group of women who are around the same age, and I can inevitably wake up at 6 in the morning and there'll be 20 texts because they're all up at 3 o'clock in the morning because they can't sleep.
Well, one of the biggest issues that I would think is in the importance of things, listening to what she says, is recognition, because some of these symptoms are so gradual. Many women don't even recognize it. They'll think, well, my husband is getting on my nerves. And they're not thinking that it's related to that. So one of the reasons I thought it was such an important show was having people understand, like, where are they in their life, their age? Are they still having menstrual periods or no? They fall in this window, and they're seeing some of these changes, they'll say, okay, well, maybe it's this and not just, some other issue, because the recognition, because gradual symptoms are harder to recognize by most people than something like you think about if you develop a cough or, pneumonia, it hits you like a flu. It hits you, something's wrong.
You know something's wrong.
But when things are gradual, they're a lot harder to recognize. And these symptoms are not, they're not like somebody coming with chest pain, or they get short of breath. This is something more salient. You may not necessarily recognize or get more irritable.
Right.
Yeah.
A lot of things can come on gradually. They can just think, well, maybe I'm stressed. Maybe there's things going on at work, or my kids have these activities and I'm probably tired, or I'm anxious. I'm not sure why. Maybe I'm drinking too much coffee. Or they'll first come and think that it's other things besides that it could be,
because they could still be having a menstrual cycle at that time.
Yes,
because then maybe that interruption has not started yet.
Exactly.
While these other symptoms are happening.
Yeah, because in perimenopause you still have a cycle. It may or may not be regular, but there's still a cycle going. So that's why I really think, especially now, it's important to talk to women about it even before they get to the age of perimenopause, so they can start kind of paying attention to when they start having slight changes in symptoms. Notice if they are becoming more anxious, more irritable. Notice if they, just feel like they just don't feel right. I have some people who just don't feel right, can't even explain it. Or joint pain. You could think, oh, maybe my workout was too hard. But joint pain is pretty common in perimenopause and menopause, just with the reduced estrogen in our bones. So it may not just be that you had a hard workout. It can be those changing levels that are, impacting.
You have to also be careful as it relates to cardiovascular risk. Now, of course, bringing my field back into it, but but there is, one thing, when women are younger, they're more protective for risk. That's why you don't see a ton of young women having heart problems unless they have, like, say, the bad diabetics or smoke like chimneys, things like that. But characteristically, they have very little heart disease until they reach that menopause age, and all of a sudden it escalates like exponentially. And that's the thing that why I thought it was important. So they recognize if they're going in it, they have to start really looking at like cholesterol levels, because the estrogen protects less inflammatory issues in vessels, because the estrogen is just protective for them. But once that starts to go away, they need to really start paying attention more to lab work, at least the stuff that outside of the menopause part, but just what it can cause.
What it can cause going forward. If you're just joining us, it's another view on health, and we're talking about perimenopause, menopause, and postmenopause with menopause physician Dr. Betyshia Belardo, and my co-host, cardiologist, Dr. Keith Newby. 757-440-2665 or 1-800-940-2240. Is menopause or perimenopause a laughing matter for you? Are you just rolling with it, or is it really causing you a lot of issues? Give us a call and let's talk about it. 757-440-2665 or 1-800-940-2240. Go ahead.
I have one question for you, Dr. Belardo. Once you start treatment, is it a pretty immediate effect, or is it gradual in terms of the improvement of symptoms, or it's based on the individual patient?
It's based on the individual, but most report improvement within a few weeks.
Okay.
Like I usually tell them to give them like 8 to 12 weeks.
Okay.
Yeah, so it's gradual because their body has to catch up.
So for the men out there who have no idea what we're talking about, describe a hot flash.
So hot flashes usually feel like heat coming from the inside and just kind of overtaking a woman until they have to stop. Either they need to get water, they can feel short of breath. They just can feel, sometimes they can just break out in a sweat, and then they can be hot and cold all at the same time. So those are kind of the severity that I tend to hear about.
And the men that are prostate cancer, we use drugs like Lupron, which is an androgen inhibitor, but sometimes it'll reduce estrogen levels as well. And then also men start having hot flashes, and I've seen plenty of men with prostate cancer on Lupron or these hormone treatments, and they'll say, "Man, I know what women feel like now," and that is real. Now I can't even speak about menopause. I'm sure you'll get into that. I'll let the expert, Dr. Belardo, tackle that.
There is a male menopause, believe it or not. What's it called?
Andropause.
Andropause.
Yes.
And that is
the male version. I will say I do mostly focus on women in this area. So I don't have a lot of men coming to me, but I have heard in terms of if they're going through that prostate treatment that they can.
Is it
have those
just
symptoms.
they call it andropause because of the androgen, like the testosterone levels drop? Is that what creates that? Do you know?
Right, because of that. And I'm also, like I said, because of that part I don't focus on as much. I'm not sure if it's more of like a social term as well, because I haven't so much studied it clinically. So, but yeah.
But women definitely will be going through
yes.
that. Also, if you've had a hysterectomy, and you decide you want hormone treatment, I know that's a factor in considering what kind of treatment you can get. Is that right?
Yes. Because if you've had a hysterectomy and you don't have your uterus, you can just start with estrogen therapy. There are benefits to progesterone as well in terms of symptoms, but if someone has not had a hysterectomy, you definitely have to have progesterone and estrogen with your treatment, because that progesterone protects the uterine lining and reduces the risk of uterine cancer if you have unopposed estrogen.
And I brought up the whole idea of the hysterectomy also because in doing the research, they also said that Black women tend to have more hysterectomies than other groups of women. And so that's another consideration that they have to take in. So I'm my daughter's going to kill me, but I have a daughter who's 43 and I have a granddaughter who's 16. And sometimes I've got the daughter in one ear and the granddaughter in the other because the hormones are going nutso in that house. What advice do you have? Because there are a lot of women who are in their 40s. Right. They're starting to go through changes. Their children are going through changes as they become adults.
Right.
What do you suggest people do to kind of go through that situation?
Yeah, my suggestion is really to focus on education. So that way you kind of know what's coming. So even for women going through perimenopause, just to kind of remind yourself of the list of the things that are common and things that are uncommon. So if you start to notice it in yourself, at least you can say, okay, you know what, that may be related to that. Let me approach it this way. Let me step back versus kind of approaching it from a way where you may get more upset versus not. And then especially with having a mother going through that and then a teen going through the menstrual cycle, of course, you're going to know what the menstrual cycle is like, but also helping the teen understand what symptoms they may have and understand that you guys may have them at the same time. Your cycles might be timing off of each other. And so maybe if both parties understand, okay, this is why I'm feeling this way, it's a lot easier to calm yourself down or rethink how you're feeling when you know where it could be coming from versus you're like, I don't know why I'm upset. I just am. But at least that way you can.
My dad was the only male with 3 females in the house. He used to just go to the den.
So forget it. I'm just
he would go to his den. He's just like, I'm done.
One of the questions I wanted to ask is the duration of treatment. If they have that, do you determine like how long you manage them on this? Is it like a time frame or is it just based on symptoms? And how do you determine, like, do you take them off in the future or you typically just leave them on? Is there an issue with long-term treatment?
It depends on the person. It depends on their personal choice. If they start it early enough, you don't necessarily have to stop it. But if they get to the point where they're in menopause, they're no longer having symptoms, then you can wean off. But again, with starting it within the right window, if you're getting that preventative and that protective benefit and you're not having any side effects or any problems, there's nothing wrong with continuing it.
And tell us what that time frame is again in terms of getting hormone therapy.
So ideally less than 60 or within 10 years of starting menopause, or if you've had surgical menopause because of a hysterectomy, within 10 years of that time frame. Okay. That's the ideal period of when you can get the benefits. You can still, in some cases, have it after that, depending on your individual case, but that optimal window is when you really benefit the most.
So do women lose their desire to have sex?
Yes, that's another common comment that I get from patients is just reduced libido altogether. And often too, it becomes a issue, with their relationships because their husbands or significant others feel that it's personal, that they're rejecting them or that there's something wrong. And that's where it comes again to men educating themselves and understanding so they can realize that when they're telling you it's not you, they really mean that it's not you, that they're going through something. And depending on their stage, they may not even understand what they're going through yet. So that is very, very common.
Yes, I have some male patients coming to me. Can you give my wife hormone treatment? does, and I laugh with that. But I seriously have had some of them ask me that, because of the decreased libido, and they think that's going to also magically get them back where they were. And I say, you really still don't know what their response is going to be.
Right.
So I said, don't get
because that doesn't necessarily mean that that's going to take that part of the symptoms away.
It may, but it may not. So I just tell them to be careful with that. So
be patient.
If you start, so the hormone therapy is to add hormones back in, so to speak.
Right.
Does that keep your menstrual cycle more regulated if you start early?
No, because the actual amount is less than the amount you would get in birth control.
Okay.
So it's not enough to shut off ovulation. It's just enough to bring up your levels to a place where it's effective enough, but it's not as high as when you're taking hormone therapy to shut off your cycle in terms of like birth control.
Okay.
Yeah.
Okay. All right. Yeah. That's.
So just while we're on that subject of, I know we kind of touched a little bit on lifestyle, but is there something to recommend to women that they could do, like certain types of dietary changes that are recommended? I know that's more anecdotal than it is actual proven, but is there changes or things that you could advise them to do that may be helpful?
Yes, in terms of lifestyle, there are a lot of things you can do with your lifestyle to help with the symptoms. First, I like to emphasize sleep. That is the most important for brain health, anxiety, fatigue. That can really get in consistent sleep schedule, getting enough. Ideally 8 hours. If you can get 6 or 7, if you can get, that's the most you can get. That really will help with those components. And exercise, especially strength training, really want to increase that lean muscle mass, not only for your metabolism, but for bone strength and overall strength as we're going forward to reduce the risk of falls and injuries that can lead to other life-threatening complications. As far as nutrition, really like to emphasize focusing on managing your blood sugar. So anything that's going to help manage insulin resistance and reduce inflammation really helps during the perimenopause and menopause period. So I like to really emphasize the Mediterranean style of eating just because it's not very restrictive, but it focuses on the things that we think are healthy anyway, in terms of lots of fruits and vegetables, healthy fats like olive oil, healthy nuts, drinking lots of water, healthy lean protein. In addition to focus on stress management. We can't get rid of stress, but find ways that work for you that help you to feel better. So whether it's journaling, of course, also really keeping in contact with friends and family, having that social interaction is really good for our health too. So I like to emphasize all of those things, especially because some patients don't want medication. They want to start with that first, but I like to emphasize that with or without medication because it really does make a big difference.
Okay. 757-440-2665 or 1-800-940-2240 are the numbers to call to join our conversation. Nicole joins us from Norfolk. Hi, Nicole. You're on the air.
Hi, Barbara.
Hi.
Listen, I want to talk a little bit about mood swings. So I wish my children were listening right now because they think I have 3 heads, and I'm trying to explain to them that I don't. What could we do? Because I'm all across the board. I have trouble falling asleep, staying asleep. I find myself staring at the wall in the middle of the night. But how can we educate our loved ones? What do we tell them? Just bear with us because they have sidebar conversations and chats about crazy moms.
Yes, they do, Nicole. Thanks so much for the call. Let's get a response from our expert.
Yes, I would say still education first, because if they can understand that it's a real thing, it's not just emotional changes on their own, that these changes are happening because biology is changing naturally.
And it's not just something in your head.
It's not just in your head, right? Yes, that it is, and it can happen to any woman going through it. So letting them know and really emphasizing, hey, these emotional changes can happen. And also too, again, going back to things for self-care, anything that can help improve sleep. And there are some supplements too, like ashwagandha has been shown to help women with supplements. Magnesium glycinate taken at night as well can help. It doesn't put you out to sleep, but it can help for more restful sleep. So anything that you can do for self-care can help. Also too, when it comes to like mood swings and helping your family, also kind of delegating more or getting them to understand that if they can help out more, that takes things off the mom's plate, so that way they have less irritability and less anxiety about things that have to get done. That leads to the increased stress and some of those mood swings, because moms are always juggling so many different things. No matter how much help we have, everything comes back to the mom first. So
Very
anything that, their spouse or loved one can do or children can do to help out in the home and with activities, that can help too.
And one of the things I would say to the men listening, when you're talking to your spouse, what I would always encourage is to be a listening ear. And when I say that, because we sometimes, we'll look at things black and white. We don't look at shades of gray. So, if you treat your wife like you're really not taking her seriously, she's going to get upset with you because she's not feeling like she's being heard and you're not taking her seriously. So I would always encourage you to really sit down, listen to what she has to say, and try your best to be as kind and giving as you can, because once they feel you recognize that it's a real issue, I guarantee their response to you is going to be more favorable than otherwise.
I agree with that. Yeah.
One question: is there anything that women should avoid doing? Meaning, like certain foods she should avoid eating, or that may make things worse.
Yeah.
Anything with high sugar, processed foods, high sugar foods, because there's a lot of data that shows that it increases inflammation. It can increase anxiety. It can even increase irritability. So really trying to reduce processed foods and really obvious sugars as much as possible.
Are there things that you can do that women in their 30s and 20s can do to start now that would mitigate perhaps or lessen some of the symptoms they may experience once they hit their 40s?
Yeah, definitely. For sure, strength training. So it's never too late to start that. Just having that lean muscle will help with bone strength, helps with metabolism, so that can reduce the risk of developing high cholesterol, prediabetes or diabetes, or any high blood pressure or any heart conditions in the future. So just optimizing your health from an earlier stage where it becomes a habit early on can help you just completely negate those issues later on. Also finding good coping mechanisms for yourself. So knowing the things that may trigger stress for you or that may trigger anxiety, either get treatment for it. I know sometimes there's stigma on mental health. If you have a concern, it's better to get treatment and to live better through chemistry. I was had a medical, one of my professors in medical school used to always say that, better living through chemistry. It's better to get treatment for your symptoms than to live without and not be able to function at your best. If you like reading, if you like going to concerts, if you like journaling, of course, exercise reduces stress. Really focus on developing those habits and those practices, so that way you know what your triggers are and you know what you can do to feel better. And focusing on nutrition too. Nobody's perfect all the time in what they're eating, but if you really educate yourself on the right foods to eat and focus on that the majority of the time, then you can have your treats here and there and you can still be okay.
You'll be okay.
Yeah.
So is there any benefit once you're in post-menopause?
One benefit is that the brain fog improves. I think another benefit a lot of my patients say is that they don't have a menstrual cycle anymore. They're pretty happy about that. Those are some of the most common ones, in addition to just wisdom of knowing and that things do get better. So it does get better over the time period. The hardest part is the perimenopause period and kind of the beginning of menopause.
And a lot of women sometimes also worry about intimacy. Does that come back, or could it improve once you hit postmenopause, as opposed to what was happening during perimenopause?
It definitely can come back. And I think that's kind of multifactorial too. Again, depending on how much support they have. Like you said, it is really important for the men in their lives to express that they understand, to listen to their symptoms and be really compassionate and empathetic. And also treating certain symptoms, especially a lot of the physical vaginal symptoms, that can be a big deterrent, even if the irritability goes away and the desire comes back. If there's any problems where they just don't physically feel comfortable, if that's not treated, that can be a hindrance. So definitely like to educate women that even if they don't take other forms of hormone therapy, as soon as they start to notice that they're having a lot of irritation, dryness, or recurrent UTIs, to get treatment at least for that. And there are still some options for libido for women. I mean, there is a newer medication, Addie, and there are ways to take testosterone therapy for women that will not cause a lot of the problems that everyone is afraid of in terms of like a deepening voice and hair growth in places you don't want to. There are ways to take it in a way that's safe and effective. So there are options, but that can get better too. Yeah.
So if we have a question. Lisa joins us from Norfolk. Hi, Lisa. You're on the air.
Hi, I'm calling to ask a question. I'm a postmenopausal woman. I'm 56 years old, and I had a hysterectomy about 12 years ago. And I'm now considering hormone replacement therapy to help me with this stage of life, being postmenopausal. I guess about 2 years ago, I started to have heart palpitations. And I'm just not really certain of what's going on. I'm associating this with lack of hormones. I've had a lot of the symptoms that have been shared in today's conversation, and I'm just looking for some suggestions.
Well, I'll take at least the first part. With the palpitations, the first question is going to be identification of what they represent, because palpitations is the perception of an irregular heartbeat. And I do have a lot of patients who have that perception but have absolutely normal heart rhythm. So I think the first thing is identification, whether or not, first thing I think is look at do you have any other medical conditions, like high blood pressure, diabetes, other things that can lead to a heart issue, lung disease. If you don't have any of that, then I think the next step is identification. Is there a heart rhythm disturbance there, which you could go to your primary care doctor. A lot of times they'll put heart monitors on you for a few days, capture what might be there. If it's nothing there, then I think like Dr. Belardo's expertise would come into play then. But that's the way I would go through that, is make sure that the heart is okay first, then move on to, because you don't want to make an assumption that it's all due to menopause, and it's not.
Mm-hmm.
Yeah, I agree. I would focus on assessing the heart health completely. Like you said, getting EKG, getting a Holter monitor, an echo. You have to send to cardiology, get that completely worked up, make sure there's no lung disease as well. Still don't want to dismiss the hormone-related symptoms, but you do want to rule out the things that could be life-threatening first. And then if there's no cause for that, also may want to look at your thyroid health as well, because if there's any components with that are out of range, that can cause palpitations. So I think it's really important to look at all the potential causes and rule out anything that may need treatment or that could be a problem, as well as while you're evaluating what the actual hormone-related symptoms are. Especially for women, if I have any women come in and they have any concerns about, oh, my heart feels like it's racing, or maybe it's nothing, I always at least get an EKG, because you don't want to miss it too, because women do have different symptoms for a heart attack or heart disease, and don't want to dismiss it and say, oh yeah, maybe it is just you had coffee. So I'd rather just err on the side of excess caution and make sure that it's not a heart issue and we don't miss anything, and then we can move on to other things.
Thank you, Lisa. I hope that helps you. So how does one find a menopause specialist?
So you can go to the Menopause Society website and you can look up specialists in your area. You can also go to the Heather Hirsch Academy clinician site, because a lot of us have taken her courses and a lot of the training, and she lists all of the physicians that are menopause certified as well. And then, of course, just talking to your primary care doctor and see how they feel about treating menopause and how they feel, if that's something that they have an expertise in it or comfortable with. Like I said, that can be your OBGYN, your primary care doctor, or internal medicine. Those are probably the more common, but any physician can have expertise in that. That's their interest.
It's, how when you go to the doctor and they ask you, have you felt sad the past 2 days or 2 weeks, and those type questions. Do doctors tend to ask women who are in the menopausal age whether or not they're experiencing symptoms? I mean, is that a part of the regular routine?
It's not, but it should be. I think probably menopause doctors do, because I know I'm always looking at the age and say, okay, well, maybe probably need to have this conversation, because you could either be starting this period or it could be coming. So I don't think all doctors ask the menopause-related questions. They may ask the depression or anxiety questions.
Right.
But if they're not focused on that, they may or may not take it to that next stage. So again, when coming back to what you should know when you go in to talk to your doctor, I think it's good to kind of keep a list of the symptoms that you may be having that you think can be related to perimenopause or menopause, and bring those in and say, hey, can we have a conversation about these things that I've been feeling? Do you feel like it could be this? Could it be related to something else? And kind of start the conversation that way. Yeah.
Wow.
Yeah, a lot of information.
Lots and lots of information. Absolutely. So, as we begin to wrap up, I wanted to, see, talk about the brain fog,
Yes,
right?
I know. I definitely experienced that myself.
Well,
It's just went straight to it. But go ahead.
Throw a recap in. So I was, and correct me in anything I say that's wrong, but I think first step is always where you want to go ahead before you forget again.
It was whether or not you should engage also with other women that are going through it.
Yes, definitely.
To talk about it.
Yeah, I think that's very helpful. Talking to your friends and family to see what they're going through within your age group, talking to your parents, aunts, and to see what they went through, because I think it wasn't talked about as much before, right. And just kind of see what their experience was. They may or may not have had severe symptoms, and I was talking to my mom, and she said that she was perfectly fine, but my aunt had a lot of hot flashes, so this experience can be different, but I think it helps just to know, one, if someone can relate to you, and two, just talking about it and see what they know. Maybe they know something that you don't, and you can learn from them. Just having that community and that support, even if they haven't experienced, just know you have support of someone and say, I hear you, I believe you. Yes, you can tell me all the things that are going on.
It's very interesting though. You said your mom said she didn't have any, but your aunts did. So it's not passed in. In other words, if your mother went through it mildly, that doesn't mean you're going to go through it mildly.
It doesn't. It's probably more likely, but it can be different for every person. Yeah. So you just, so that's why it's really important to be aware of the symptoms. So that way you can know if you're starting to, experience them, but also know that everybody's going to be different. So your friend may have one symptom and you may have another, and treatment plans can be different, but it's still good to talk about it, because the more you know, the more awareness, it just helps and it makes everything easier.
Dr. Newby.
So I'm not, of course, big fan. People know who I am. I always tell people stay off the internet unless you really know what you're reading. But I think if you go on there to look at symptoms of menopause, at least have an idea of what they are. I wouldn't do or not do treatment based on what you read, but you want to be able to identify, recognize where you are in your life, understand the potential that you have, because I would say something different for a 50-year-old woman versus a 20-year-old woman.
Right.
So recognize where you are, understand what those symptoms might be, keep an open mind to the possibility that you could be going through something along that line, and then seek the treatment. Go see your doctor. Stop ducking and dodging us, because that's not going to help anything. Because if there are other medical conditions you might have that have nothing to do with menopause but have similar symptoms, you could potentially miss out on getting treatment that otherwise would help you get better. So early recognition, see your doctor, seek out a menopause specialist if you need one based on what you read, but make sure you ask your doctor, do they feel comfortable with this treatment? Because they don't, you need to see somebody for that particular part.
Yeah. I agree. It's really important to look at the whole package. So you don't want to brush off anything you're feeling, but you do want to be realistic to see what your current medical conditions are, what you're feeling. You don't want to miss anything. So it's good to go in and get a full evaluation.
Thank you guys so much. As always, the hour is gone, but great information. And we hope, audience, that you enjoyed today's edition of Another View, and it will help you or someone you love on their menopause journey. Check out the podcast of this show or any of our Another View programs at WHRO.org, Spotify, or whatever platform you use for your podcast listening pleasure. Next week on Another View, country music singer Roberta Lee. She has a new project out just in time for Women's History Month. And also want to say, now we got our second group of interns, and they are from Chesapeake Public Schools. Nani from Oscar Smith, shadowing WHRO employees all week. 3 students from Norfolk Collegiate, Chris, Peyton, and Alexa, and also MJ from Norfolk Collegiate. There you go. Our theme music is an original composition created especially for Another View by Jay Sennett. Lisa Godley is our show producer. Jordan Christie is our audio engineer, and Dr. Barry Graham answered our phones. Have a great weekend, everyone, and let's get together again next Thursday at noon for Another View.
Support comes from Hampton Roads Community Foundation, carrying out your charitable wishes forever, whether it's helping shelter animals, feeding the homeless, enhancing the arts, or supporting students. Learn more at leaveabequest.org.